You may ask, why are we talking about this in this conference? And the reality is it's because, one, we're all going to face this, no matter what field you are in medicine, primary care, orthopedics, neurosurgery, physical therapy, chiropractics, OBGYN. I don't know if there's a lot of OBGYNs here, but if you are, welcome. This is for you, because we all end up managing this at some point in our career. And second, because in order to manage it well, it really requires an interdisciplinary approach. And that's what this conference is all about. So in the world today, there are certain questions that you have to ask. Are we ever going to get an answer to this? Some examples are, why is it that Californians and Utahns both think that the other group are the absolute worst drivers in the world? I don't have an answer for that one. The second is the image file GIF pronounced GIF or GIF? I've heard it both ways, so it could go either way. And then the third being, how can I figure out if my patient has sacroiliac joint pain and what can I do about it? Now, I'm not going to do anything to answer the first two, but that third one, that's the point of the next few minutes today. So we have to be honest with each other that when it comes to managing SI joint pain, it is quite literally a pain in the butt for both the patients and the providers. And so one of the reasons why it's so difficult is because the anatomy is so unique. And when it comes to the sacroiliac joint, it has two different aspects of the joint that are very opposite each other. The superior part of the joint is almost more like a symphysis. So you have these really dense ligaments that hold everything together, and even an interosseous ligament that runs in the joint. The inferior part of the joint is a true synovial joint. It has articular cartilage, it has a capsule, it has fluid in there. And so you can think about it like we have a joint here that has two very different parts. And in that sense, you can kind of think of the SI joint as the mullet joint of the body. You got these two parts that are just really distinct and seem to contradict each other, yet at the same time it just works. And so don't be distracted by the mustache. It is phenomenal, but that mullet was voted the 13th best mullet in the United States. And we have to be honest that if it were running for president, it would be a legitimate third-party candidate if it did. So we understand the anatomy. Now, how do we figure out if our patient's dealing with this? And as in most things in medicine, we are talking about getting a good history and performing a good physical exam. And for history, these patients are going to come in with pain more often than not, and it's going to be localized mostly to the low back and buttock area. However, it can also radiate down into the leg, even as far down into the calf, and it can go into the groin as well. So if you have someone come in with those symptoms, you start thinking, what kind of exam should I do in order to define if this is the SI joint or not? And there are a lot of different tests. I'm going to list a few of them, but there are a lot more than even these. The easiest one is Fortin's finger test. You say, where does it hurt? They point right over the SI joint, positive. That's the simplest test you could do. Other ones that we have are the compression test. Compression test is where they lie on their side and you press towards the ground on the lateral aspect of the hip. The next test could be the distraction test. They lie on their back and you push posteriorly on the ASIS bilaterally. Faber test would be next. You cross the leg over and you push down posteriorly on the knee and on the ASIS. And then we have Gainsland test, where you bring them to the side of the bed and you drop that leg down towards the ground. And thigh thrust is another common one, where you flex the hip at 90 degrees and you push posteriorly on the top of the knee. Now, if any of these tests reproduce their pain, you have to think this could be sacroiliac joint pain. And if you can get 3 positive, then you can be really confident that, yes, that we have the accurate diagnosis. Now, you can ask, what is imaging's role, what is the role of imaging in SI joint pain or in diagnosing it? Well, X-rays and CT scans can show signs of degeneration, joint space narrowing, osteophyte formation, subchondral sclerosis. MRIs can show inflammation around the joints, especially in inflammatory arthritis, things like ankylosing spondylitis. It can show tumor, it can show trauma. But the reality is that imaging when it comes to the SI joint is more helpful in ruling out other causes of pain than it is to actually confirm the SI joint is the source of pain. So we're just trying to really make sure that we're not missing anything else. Ultimately, the gold standard right now for diagnosis of SI joint pain is a diagnostic injection. So you take a needle, you place it into the joint, and you inject local anesthetic. If they can get 70% relief or more of their pain during that time, then you have your diagnosis. Now, it's not perfect. You still get false positives in there, but at this point, that's the best thing that we have. So as we're coming to the diagnosis, we're going to use all the information available. We're going to lean on each other. We're going to gather all the data that we have and get confidence in our diagnosis. And then the question is, what do we do about it? The advantage of SI joint pain is the vast majority of them can be treated conservatively. And that's where we're talking that interdisciplinary approach. This is using things just like simple oral anti-inflammatories, physical therapy, chiropractics, bracing, even just something as simple as a shoe insert to help those who may have leg length discrepancy. These things can be sufficient to get the pain under control, get patients back to where they're living their normal lives and doing the things that they want to be able to do. Now, if that's not enough, oftentimes the next step is to move on with an injection into the joint. Most often it's a corticosteroid injection. And what that involves is injecting a steroid into the joint, which reduces the inflammation and often can provide relief that lasts on average between 4 and 6 months. You have the downside of the steroid side effects though. And so there are some studies that show that you can inject PRP or platelet-rich plasma into the joint and actually get the same relief as the steroid, and it lasts even longer, up to 6 to 9 months. The problem with that one though is that insurance doesn't really cover it very well. So oftentimes we're left with the steroid injection. If that doesn't take care of it, we still have more options. We have the surgical option, and what we're talking about with this is the fusion option of fusing the SI joint. Now, even as recently as 15 years ago, when we talked about SI joint fusion, that surgery, it was a bloody mess. And that's not like me being a British person swearing. Like, there was a lot of blood loss. It was an open procedure. And there were a lot of comorbidities that went along with it. Fortunately, in the last 5 to 10 years, there have been significant advances in minimally invasive fusion techniques. And a lot of times we break them down by the approach that's used. So the one that has been probably around the longest and has the most evidence behind it is the lateral approach. So you insert devices coming in, the lateral aspect of the ilium, it spans across the joint and goes into the sacrum. Significantly fewer complications compared to the open fusion. However, there still are potential risks. You can damage one of those nerve roots that's traveling through the sacrum, which can lead to long-term nerve pain that goes into the pelvis or into the leg. Neurosurgeons are the ones that do, and orthopedic surgeons are the ones that do this type of a fusion. There's the posterior approach. And this is where we make a small incision in the skin over the backside of the joint. We distract the joint open and place a device into that joint and try to fuse it across that device. Fewer complications even than the lateral approach. Very rare to have a neurologic complication with this one. And this one, it can be done by both neurosurgeons, orthopedic surgeons, as well as interventional pain specialists. And then there's kind of the hybrid approach, which is a posterior-inferior approach that still spans the joint. You don't have to insert anything into it, but it fuses the joint that way. Which approach is best depends a lot on patient factors. And so once we've identified the cause of the pain as the SI joint, we've gone through some of those early stage treatments, they haven't worked, it's best to kind of let the individual who will be doing the surgery decide maybe what's the best approach for this person. So in summary, the SI joint is complex. A lot of that is because of the anatomy itself. The more confident, the more positive findings we have on exam and in history, the more confident we can be in our diagnosis. More often than not, we can manage this with an interdisciplinary conservative approach that doesn't require any type of intervention. But if necessary, those minimally invasive interventions are becoming more and more popular and more successful with fewer side effects associated with them. Thank you.